Good evening. This is Dr. John Bennett, broadcasting from Ratnagar, Nepal. I have the pleasure of having with me tonight Juha Hernesniemi, a neurosurgeon from Finland, now in Nepal, obviously, with me. And he's going to give a presentation for the neurosurgical TV. And I'll let Juha introduce himself and tell what he wants to talk about. Okay, Juha, it's all yours.
Hello, everybody. As you see, I'm doing first time this kind of presentation after having given all around the world more than 1,000 lectures. So I need some help here. So, and I will go to my lecture, tell something about the philosophy, and I mainly speak now about posterior fossa tumors. Because 2 days ago I operated one tumor, so this is the basics and background to speak about posterior fossa tumors and how I'm used to do them. And I have done endoscopy in the 90s, and I have done my first lumbar disc under microscope 1979, so it is a long road I have back. So let's go to my presentation. So
okay, this is not a special effects, folks.
Okay, I speak about posterior fossa tumors. I'm coming from Helsinki, Finland, where I used to be professor chairman 18 years since 97, and there's a law in Helsinki or Finland that with 68 years you have to retire. So after this retirement 2 years ago, I have been going around the world and I've been working in Peru, Indonesia, USA, and now I'm here in Nepal, Ratnagar Nobel Institute for Neurosciences, and head of the neurosurgical unit under the direction of Dr. Juha Hernesniemi. So, about the patient background for this presentation. So we had, I operated 2 days ago, a male, 55 years old, otherwise healthy, but he had a plaque on the parotid region, left side, but this has been already 15 years. But 2 days ago, I operated on this patient, male, 55 years old, with headache and dizziness, otherwise rather healthy, former smoker. And in MRI, you can see this finding, which I discussed. Maybe you hear me? Okay, it's okay. So you hear me, and the possibilities of this right-sided, rather deep, located posterior fossa cerebral tumor that is at the tentorial height, was very close to the pineal region, which is one of my favorite sub-specialties. So I have operated close to 200 pineal tumors. And published also on them. So I like to do them in a special way, not well accepted around the world, but this is the best way that I operate in sitting position. I will speak about the sitting position and operations of these tumors. So this is the MRI once more, and this is MRA. You see there is no vascular, big vascular lesion to be seen. This was done because we suspected it might be a hemangioblastoma, which are very vascular and need very different surgical care. You cannot go inside hemangioblastoma. If you go to inside hemangioblastoma, so you may kill the patient. So you have to do completely different surgery than in other tumors. So this is just to exclude the rare tumor, hemangioblastoma. This is the sitting position we built up here first time in Viratnagar Nobel Institute, and to make something new in a new institute is completely different than in sports. You can go to play soccer somewhere and you can be extremely high level, but to do surgery is 10 times more difficult. So you cannot simply go and to do that kind of surgery in a different place, because there are so many different variables besides technical, also personal, and different languages. There are different languages. There are spoken language, and then there's a surgical language, and this is one of the important things. So, but we did well here, and this is a post-operative CT after. So you see there's some blood to show where we have been. This is joking saying that you see that the patient has been operated on, but the tumor has been taken away through a very small occipital, suboccipital opening, supracerebellar, infratentorial, going over the cerebellum to the tumor. The patient was in sitting position. So something about the philosophy of neurosurgery, of my experience. My teachers have been Professor Ryanbury, Yasakil, and Dr. Drake, and with Dr. Drake and PLS, we published a book on cerebrovascular aneurysm 25 years ago. So there's a nice sentence from many hundreds years ago that you should publish what might help other people to do some tasks. So you should publish your tricks and not hide them, but you should also publish your complications. So my teacher, Dr. Drake, always said that you have to be so honest that it hurts. And this is one of the very difficult things in surgery. There are many reasons for that, and especially in neurosurgery, you are faced with a lot of difficulties, complications, and neurosurgical life is colorful, like this here you see mine. So after 44 years in neurosurgery, so I still can say that I'm happy and addicted to neurosurgery. I studied in Zurich, Switzerland, neurosurgery and medical science, and I saw Professor Ryanbury and Professor Yasakil, and that's why I became neurosurgeon. And then I went later also to great Professor Drake and Professor PLS and around the world. So I've been around the world, sitting in the different corners of all operation rooms more than 3 years, and I think this is extremely important to go around. And nowadays it is so easy to go around because you can send an email somewhere and then you get the answer by a proper person immediately, and you can take a flight, and next day you can be around the world. You can be in Nepal, you can be in Rio, India, Australia, wherever. So it is easy to travel now, good or bad for tourism, but to learn some new things, it is always very good. So I was trained in a long time ago, in 70s, and I became neurosurgical specialist in 1979, and this year I made under microscope my first lumbar disc operation. My first aneurysm I operated in 1976. So this has been my life, and I have published a big number, more than 600 publications, and but my main thing has been to do surgeries, and so I have done more than 16,000 surgeries in, myself, and have been involved in more than 70,000 operations. In 2 institutes in Finland where I have been working, in Kuopio and Helsinki the last 18 years, and then around the world I have been operating in 3 continents, and except Australia and Africa I have not been operating on, but in all other continents I have been operating on hundreds of patients. So, but I never went alone. I had my team there, and so we did good surgery, because I always felt safe when I had my own instruments and my own scrub nurses with me. So something about the history of the neurosurgery. So I was studied in Switzerland, Zurich, neurosurgery, and microsurgery was developed by Professor Yasakil at the end of 60s. And Professor Yasakil was very famous about that as a pioneer of microsurgery, that no one could say any word in the operation room, not even treat or make a smallest sound if you were coughing, and then he was telling to you that you are sick, go out, you are infecting my patient, and so this was very strict discipline there. After the lectures, we international students went to a restaurant in Zurich here, one old photo from Zurich Weiser Wind. And this is very encouraging and important photo for you young people, because this guy on the right side or left side, depends from how you say, but this guy here with my arrow, I'm pointing on him. So this is Jesus Martinez from Mexico, and you see these are international guys around the world. One evening after we have seen Professor Yasakil's miraculous operations, which were something like Usain Bolt now was the superior sprinter, and then there was nothing. He won all the things. So that time, 70s, 80s, Professor Yasakil was #1. Then there was nothing, and then some other neurosurgeons. So it was like a Mecca pilgrim place for 3,000 neurosurgeons, and so we went there, and after the surgeries we were discussing the surgeries, and what was the important sentence. This Jesus Martinez, he told one evening that one day we will be better, and it is so. In every area you will be better. And when I look back on the videos from the 80s, 82 from Yasakil, so we are doing better now. And I have told that also Professor Yasakil recently, even he cannot accept it. So this is why my first fellow, Hu Shen, has drawn this drawing, Professor Yasakil operating on in Helsinki, and he didn't speak well English, Hu Shen, from China, but he was excellent artist and excellent neurosurgeon. And you see this picture, when you take a look at this picture, it doesn't look it is from Helsinki, looks like it's from China. So we look at the world with different eyes. So one of the advantages to work in a small country like Finland with 5.5 million people is that you know your patients, and you have extremely good follow-up. So Finland is famous for epidemiological studies, and all the patients are coming to one center, because the country is divided to 5 parts, and there are only 5 neurosurgical centers, Helsinki being the largest one, with 2 million catchment area. So we take all the patients, and this is one of the things that we see all the patients, and we can follow up for every case. So this is my chairmanship years in Helsinki. So during this time, we treated every year more than 3,000 patients, and this patient is sitting position. The patient has a big tumor close to spinal region, but it is mainly above the 10 thorax. So we are preparing the patient to go in the hemisphere, which seldom in my practice. Usually I'm doing supratemporal and intratemporal approach. And, small things are extremely important in preparation of the patient for the microsurgery. So very small things count. And one of the treats cases in the sitting position is the famous air embolus, and many anesthetists refuse to make anesthesia in this position. But when you get used to it, you get experience like in all areas, so you feel very safe with this area. And which are the advantages of this sitting position is that there's actually no bleeding, and then when you go to the above the cerebellum, then the gravity is helping you to see the Tisser Oliveira, this from very famous neurosurgeon from world famous neurosurgeon from South America, Brazil. So preparing the site, I'm always doing this myself. Learned from Professor Elrike to do that myself, and I being a wound, was the wound myself, and this is why I'm doing that, is concentration for the operation. So I'm all the time concentrating for the operation and thinking how the different steps, and think how the tumor or aneurysm is inside, and how it is located. And I speak with the anesthetist about the blood pressure and which anesthesia is, as if they gave already mannitol, so thinking about the intracranial pressure, and then small tricks, for example, this alcohol should not go rings on the back because the patient might get burn wounds. So very small things may cause big problems if you make some errors. So it may look easy, like dancing on the rope in circus or making some acrobacy in circus, but it needs training and experience of long time. So this is one of the important things that you need. You can begin neurosurgery at the age of around 25, earliest. In some countries even earlier, but usually you are a neurosurgeon when you are 30 or more years. It's local anesthesia, so and also to prevent any bleeding from the wound. So there's the well-known rule that how much have you trained? So 10,000 hours when you train, then you're at the world top. And in tennis or golf or some other areas, playing violin or piano, so you can begin with 2 years, even younger. But in neurosurgery, you cannot begin that age. So 10,000 hours are coming later, and at your best you are when you have been 10,000 days in operation room. So this means that greatest experience is coming around when you have been 30 years in neurosurgery. So then you at your best, certainly. But different from sports, you get even better. And I still think I'm developing and learning a lot. So my professor in neurosurgery, in anatomy, Giant Thundery, he told always with loud voice that medical study is a lifelong study, and to learn anatomy even more. So the most important thing in neurosurgery is to know anatomy, and then, of course, many other technical things. But one thing is sure, that you cannot do neurosurgery alone. You have to be social, and you have to manage with many different people, and you are a team. So here you see Helsinki, it is summertime, so three short months, and I'm cleaning the floor. Why? Because I slipped when I was resident, when I was doing a stereotactic procedure, and it was another story. But this is how you learn. And one of the good sides when you have difficulties, technical difficulties in giving lecture, is that no one died, no one was invalidized. But this is one of the good sides. There was a famous actor in Finland, and he began 75 years, and he was telling in his interview, and actually I operated his daughter for a brain tumor. So he was telling in the interview that he's always so nervous before. He's always a performance. So he's always extremely nervous, and he was 75. So I didn't dare to ask him why he's so nervous. So, but of course, this always when you try to fly high like El Condor, this is the bird that is flying highest in the world. So you try to reach and do your best, and that's why you are nervous. In theater performance, no one is dying. No one is invalid. So that's why the surgery is unique and one time. And if you have technical difficulties in lectures, so one of the good things really is that no one died and no one was invalidized, like it happens with surgery. So when you are doing surgery, it is good to have in mind that way. Surgery is only one time, but next time we will do better with the lectures. Forgive us technical difficulties. That was the first time I did that kind of presentation. I thank you very much for your patience, and I hope we meet again. Thank you.